Welcome back to Decode Healthcare with Harshal. So in part 11 of our Musculoskeletal System Explainer, we tackled the massive codes for the femur and the knee joint. Today, we're heading further down. It is time for part 12, where we're going to completely demystify the 2000 series CPT codes for the lower leg and ankle. Specifically, we're looking at codes 27600 through 27899. And we're going to do this by stripping away all that complex medical jargon and just breaking it down into simple, plain English anatomy. Here is our agenda for today's explainer. We'll start with lower leg and ankle anatomy, move into repairing the Achilles tendon, then break down complex ankle fractures, look at arthrodesis, and finally wrap up with below knee amputations. All right, let's kick things off with section 1, lower leg and ankle anatomy. Now, to really get these codes, you need to know the foundation. Your lower leg essentially consists of two main bones. First up, the tibia. Think of this as your thick, heavy, weight-bearing shin bone. It literally does all the heavy lifting when you walk. And right next to it, we have the fibula. This is the much thinner, kind of delicate support bone that sits right on the outside of your calf. Whenever you see CPT codes referencing the leg, they are specifically talking about these two bones. Okay, as we move down into the ankle itself, there is one very specific term you absolutely have to master: the malleolus. Now, what exactly is a malleolus? It's really just a fancy word for those prominent bony bumps you can actually feel on the sides and back of your ankle. You've got a medial malleolus on the inside, a lateral one on the outside, and a posterior one on the back. Keep these bumps in the back of your mind because they are going to be the entire basis of our fracture coding rules in just a few minutes. Moving on to section 2, repairing the Achilles tendon. So the Achilles tendon is that super thick band of tissue connecting your calf muscles straight down to your heel bone. It's an incredibly famous sports injury, right? When an athlete pushes off way too hard, that tendon can literally snap right in half, totally disconnecting the muscle from the heel. To fix it, surgeons go in and basically sew those snapped ends back together using really heavy sutures. But here's the trick for codes 27650 through 27654. You don't just grab a generic repair code. You actually have to select your code based on the exact timing of the surgery. The absolutely critical CPT guideline difference here is choosing between a primary repair and a secondary repair. A primary repair, which is code 27650, happens right after the injury. The torn ends of the tendon are fresh, so the surgeon can just pull them together and stitch them up end to end. Nice and straightforward. But a secondary repair? That's done much later. Over time, those snapped tendon ends actually shrink, they retract, and they get covered in scar tissue. The surgeon can't just pull them back together. So a secondary repair often requires harvesting a tissue graft from somewhere else in the body just to bridge that huge gap. It is a way more complex surgery, and that's exactly why it gets its own dedicated code. Next step, section 3, complex ankle fractures breakdown. This is probably the most crucial coding lesson for this area. When you're analyzing fracture codes 27808 through 27822, the foundational rule is actually surprisingly simple. You just choose your code based entirely on how many of those malleoli bumps are broken. Remember those bony bumps on the inside, outside, and back of the ankle we just talked about? Well, the rules for repairing these pretty devastating fractures depend strictly on them. So it's really just a numbers game. You're counting. If the surgeon's operative report mentions a bimalleolar fracture, well, the prefix bi means 2, so 2 of those bumps are broken. If it says trimalleolar, tri means 3, which means all 3 bumps are shattered. The complexity of the operation, and of course the code you ultimately select, scales up directly with how many of these specific ankle structures have been destroyed. But wait, counting the bumps isn't the only rule here. You also have to code based on whether the surgeon used open treatment. Now, in coding terms, open treatment does not mean the bone popped out through the skin. It actually means the surgeon surgically opened the ankle to directly look at the broken bones, and then they applied internal fixation. Basically, they screwed metal plates directly into the fibula, or they drove heavy screws right into the tibia to hold all those shattered pieces together so they can heal. If they just set the bone in a cast without making any incisions, well, that would be closed treatment. Moving right along to section 4, arthrodesis, or fusing the ankle. Now, arthrodesis is the official medical term for joint fusion. And honestly, this brings up a truly fascinating medical question. Why on earth would a doctor intentionally perform a major surgery designed to permanently eliminate the movement of a patient's ankle? Well, the answer really boils down to quality of life. You see, if a patient has had severe trauma or maybe end-stage arthritis, all that nice protective cartilage in the ankle is just totally worn away. So every single time they take a step, it's raw bone grinding on raw bone. It is agonizing. To stop that pain, the surgeon performs an arthrodesis. They literally drive these massive metal screws through the tibia bone and straight down into the talus bone of the foot. By locking those bones together, they stop the friction entirely. Sure, the joint is never going to bend again, but the patient can actually walk without excruciating pain.
Okay, Section 5, below knee amputations, commonly known as BKA. Let's look at the CPT manual for code 27880. This specifically describes amputating the leg straight through the shafts of the tibia fibula. In the medical world, this is a below-knee amputation, or BKA for short. The surgeon cuts cleanly through those two lower leg bones we discussed earlier, which effectively removes the lower calf, the ankle, and the entire foot.
Now, thinking about this procedure, you might wonder about the surgical approach itself. I mean, why go to all the massive trouble of sawing straight through the incredibly thick, hard bone of the tibia and fibula mid-shaft? Wouldn't it be so much easier to just disconnect the leg right at the natural knee joint where the bones are already separated? It really is a great question, and it perfectly illustrates the ultimate long-term goal of amputation surgery. It is entirely about the patient's future. Saving the natural knee joint is absolutely critical because it lets the patient keep a ton of mobility and leverage. When they eventually get fitted for a prosthetic limb, having their own natural functioning knee makes walking, sitting down, and just navigating the world exponentially easier than if they had to use a completely artificial knee. Every single inch of healthy bone a surgeon can save literally changes the patient's life. So now that you've seen how just mastering some basic plain English anatomy completely unlocks the CPT codes for the leg and ankle, I want to leave you with a quick thought. Your ankle is basically just two bones and a few bumps, right? Well, your foot has 26 individual, highly intricate bones. How much more complex do you think the coding rules are going to get when we tackle the foot and toes? Make sure you are subscribed to Decode Healthcare with Harshal, because in part 13, we are diving into exactly that. Thank you so much for hanging out with me for this explainer, and I will catch you in the next one.